Welcome, everyone, to today's webinar presenting highlights from Chilmark Research's latest market scan report, Telehealth 2018, Vendor Assessment and Market Outlook. We'll also afterwards have a conversation with two industry leaders about telehealth adoption. To join us, we have our Chilmark founder, John Moore, who will be sharing his screen to present key highlights about our report. We also have our panelist, Ann Mon Johnson, the CEO of the American Telehealth Association, and Dr. Brian Zach, who serves as the Medical Director of Telehealth Services at University Hospitals, Cleveland.
Hello, everyone. John Moore here. Hello, Ann. Hello, Dr. Zach as well, Ann and Brian. Great to have you on board. This is the Chilmark team, and this is Chilmark Research. We are an analyst firm based here in Boston, Massachusetts, and we are united under a core belief of helping the industry, and in particular providers, adopt, deploy, and use technology to advance the care delivery chain and actually lead to better patient experiences and outcomes. We have been doing this, and we've been on this journey now for, it'll be 12 years next year. And we do this through the research that we conduct on a variety of technologies, from population health to analytics, care management, and of course, the topic of today, telehealth. The panelists we have today are, of course, myself, and we have Ann Mon Johnson, who is the Chief Executive Officer of the American Telemedicine Association. And lastly, as Hannah mentioned, we have Brian Zach, Dr. Zach, who is the Medical Director of Telehealth at University Hospitals in Cleveland, Ohio. So now let me get on to what we here at Chilmark Research defined in terms of our recent report that was released last month on the telehealth market, where we did an vendor assessment and market outlook. The key definitions we used was that telehealth is the remote delivery of communication of healthcare services and clinical information that leverages telecommunications technology and may include devices for remote patient monitoring. We looked at three core markets: direct-to-consumer telehealth, acute care telehealth, and remote patient monitoring. This is a report that just came out from CMS. It was released. There was a report to Congress on Medicare and telehealth that Congress asked CMS to perform. It was released on the 15th of November. And what you see here is, although actually the actual number of beneficiaries using telehealth services is fairly small in relation to the number of total services provided in a fee-for-service model through CMS, there is pretty outstanding growth in the move to telehealth services, particularly for those services. And this is from 2014 to 2016. For outpatient services, we saw a 50% growth in that short time frame. And also with psychotherapy and mental health type needs provided through telehealth, there was a 173% growth rate in that one market or application of telehealth services. It's also, I would like to mention, if folks haven't seen it yet, this month's issue of Health Affairs looks directly at telehealth. The whole issue is devoted to telehealth. There's some very good papers in there. I would advise everyone to look at those papers if they've got that subscription. Okay, telehealth growth drivers. What we're seeing in terms of the really driving growth for telehealth today is certainly consumerism and providing ease of access to telehealth services. We're seeing this across the market, from payers providing it to kind of improve the ease of access to providers, and more importantly, healthcare organizations themselves, such as university hospitals that Dr. Zach will talk about their own implementation, where consumerism is really what they're trying to get at. They're trying to tap into the new generation of, let's call, quote unquote, millennials that are really looking for the easiest way to access healthcare services on an as-needed basis. There's also been lowering barriers to reimbursement. For example, most recently, Medicare or CMS announced that under Medicare Advantage, that telehealth will become a basic service under Medicare Advantage plans. This should, make it comparable to basic, inpatient or type services or visiting a physician's office and comparable in reimbursement. There's also growing familiarity and acceptance amongst patients in the use of telehealth services. Although this growing familiarity has been slow, and I believe is still one of the major drawbacks to seeing huge adoption of telehealth to date. A medium impact is reduced cost, again, getting back to utilization management. Employer demand. A big issue with employers is absenteeism of their employees. Having employees leave to go to a doctor's appointment takes them out of the office. If an employer can provide those types of services while the employee is at work, so much the better. There's certainly the physician shortage issue, particularly in rural areas where access to healthcare services can be difficult, and the need to increase patient activations, specifically around chronic care management. And then what we saw in the market in our interviews with a number of stakeholders in the marketplace, low impact was improving access to care for the underserved and the centralization of telehealth resources. And of course, with any market, there's always challenges to adoption. In the high impact category, there's a lot of integration challenges that continue today along the delivery chain in terms of how these telehealth services will be used by a given patient or consumer, the results of those encounters. How do they get into the longitudinal patient record if that encounter occurs outside the normal network of provider services that someone might be getting from their in-network provider, for example? There's also external competition from retail, urgent care, et cetera, that are also coming into play, also competing for that patient visit. A medium impact is the patient preference for in-person care. I believe this will probably in the next 3 years move into the low impact care category as people find the convenience of a telehealth service versus having to make the trip to an office, sit in a waiting room, and then finally get seen and then drive back home or back to work. There's also a patchwork of physician licensure rules which continue unabated. We're slowly getting some resolution on that, but not completely yet. And lastly, reimbursement parity. We're almost there. This will probably fall off the map in 3 years easily. I don't think that's going to be much of an issue in the near future. And there's also just the issue of tactical execution. So when we looked at the market, as I said earlier, we looked at 3 markets. The big one that's getting all the press today is really the direct-to-consumer. These are where you see a lot of the big brands out there today, American Well, MD Live, certainly Teladoc. All these companies have pretty strong brand awareness out there. It's important, and so these are all good companies out there. The ones that are highlighted in this box with the various logos, the blue ones highlighted, are ones that were actually profiled in the report. This is the fastest growing market sector, but there's also a significant amount of merger and acquisition activity occurring amongst these various brands, and some picking up smaller specialty brands to meet their need. For example, Consejo Sano is a telehealth service for Hispanics. And it would not be surprising to see one of these larger telehealth vendors acquire a service like that to meet the Hispanic needs of the Hispanic population. 24/7 availability of these services plus low price. It has a high appeal to consumers, but it lowers the margins. So a lot of these vendors are starting to move to an OEM platform model where they're literally transitioning from providing the doctors themselves to OEMing their telehealth platform to, say, a healthcare organization such as a university hospital system, universities, hospitals in Cleveland. And then that hospital system will use that platform to provide their own telehealth services to the region that they support. I really believe there's an untapped potential for condition management that none of the vendors today have done very well. CMS reimbursement models are coming into play here. This may jumpstart this market. In July of 2000, there was a new proposed fee schedule for physicians proposed by CMS that's going to be enacted in 2019. And of the three services that they're looking at with regards to telehealth, one of them is prolonged preventative service. I believe that is directly related to condition management. With CMS taking the lead there, I think others, commercial payers, will follow. Acute care, this is really a B2B market where, say, a large academic medical center is providing specific services to, say, a rural hospital around specific specialties. It tends to have very large scale implementations, and it's been a relatively stable market. The emphasis is on high acuity care and support, so it's cardiology, oncology, a big market for this, a big diagnosis market for this particular space was stroke identification, because patients that have suffered a stroke need to be treated quickly. I forget exactly the time limit, but it's a very short time limit to give them the correct medication to minimize the damage of the stroke in a given window. Again, as I mentioned earlier, resource-constrained rural health facilities are the near-term opportunity. The challenge here is that those rural facilities really don't have the bandwidth to support a multiple of these types of services. So the challenge for these service vendors is to aggregate enough specialties under one roof to provide that complete service to a rural hospital system. And lastly, kind of off to the side here, we have remote patient monitoring. This is very much a data-centric services triggered by data feeds. So it's more of a passive sensing and monitoring of a patient, say, post-procedure, or it could be chronic care management, but monitoring that patient kind of in real time with data being fed into and aggregated to track and monitor the patient over time. The challenge here is really requiring some sort of context to the information that's being collected. So you really need a tight linkage between what you're monitoring and measuring and the clinical care plan, so that you have a relationship there that, for a given, say, a patient with COPD and diabetes, you kind of know the baseline, you know what measures you're tracking, you know what the outliers are that would require an alert, because last thing you want is alert fatigue with these types of services. So it does require some fine tuning and putting those data feeds into the context of a given patient. That personalization is going to be needed. What we really see here developing in this market is kind of the transition towards smart home and digital therapeutics, which had the potential to disrupt the broader telehealth market. These are the virtual assistants, sensor networks, and of course, mobile first technology through apps. So getting to that, these potential market disruptions to the, what has been traditionally called, the traditional telehealth market, which is more that video visit between a physician and a patient, is, for example, the smart home. There's certainly a lot of consumer interest in this. The technology is advancing very rapidly. The question is, with this type of smart home technology, can you target the right population? How do you configure the right sensor mix with the right platform, with the right data model to use that in the context of monitoring, say, a chronic care patient or a post-procedure patient that's recovering at home? And you really begin to wonder, are passive sensors the end game here? That still remains in question. There's also third-party care, and we talked about this earlier as a potential adoption challenge. There is still that preference by patients today to like the in-person visit. We see that fading a bit, but these retail and urgent care clinics really don't, they're not going to want to give up anytime soon. And so there's going to be certainly some price competitive services and challenges there between these two markets as they vie for position. I think, the big issue here is, will the data and care be siloed? Again, getting back to that longitudinal patient record, how will that data be reconciled to create a consistent record for the patient? So whoever has to interact with that patient, whoever the clinician is, has some idea as to what has transpired beforehand. And secondly, can the facilities handle the workflow disruption that these third-party care services can create? The kiosk, that's one of the things. I'm not really too worried about this one. This is something that's been tried for a number of years to date, where particularly at employers, where they will put a kiosk in place to help their employees manage and monitor their health. And there's been some work of putting these kiosks in communities, but there's been the evidence on those in terms of the outcomes being any better is far from conclusive. Lastly, digital therapeutics, kind of enabling the ongoing engagement and management of a patient with clinically validated support. This is something that's of high interest to pharmaceutical companies as they look to couple digital therapeutics with a given medication regime that a patient may be subjected to, say an oncology patient. The question here is who actually pays for these digital therapeutic services. The reimbursement models aren't there yet. How does it fit into clinical workflow? And I'm not sure if it's really true telehealth competition. I think it's kind of fits into the remote monitoring realm. So lastly, my last slide here, looking at the market, how the market outlook and adoption trajectory over the next 10 years. So within the next couple of years, really it's going to be the big issues are going to be data management, convergence, and white labeling. So the data management, that's what I've been talking about when I talk about how do we get the data, normalize the data between an in-person clinician visit with an in-network provider, for example, and a patient slash consumer, accessing some sort of telehealth service. How is those going to be reconciled? How are the encounters going to be brought together to actually track and monitor, and create that longitudinal patient record, and who ultimately has responsibility for that? I think we'll also see proprietary devices kind of out of favor. These are, particularly devices around telehealth devices. We're going to move towards more of a bring your own device type modality, common iPad or an Android type device. On the convergence, more parity with existing reimbursement models. And the white labeling we spoke about already about the HCO, healthcare organizations, that's what HCO stands for, seeking brand recognition within the communities they serve by providing these telehealth services. So, for example, a company like an MD Live will OEM their platform to a healthcare organization, and that healthcare organization will stand up their own telehealth service with their own providers. For the vendors, it also means they're probably going to be employing fewer docs and providing just more flexible platforms for healthcare organizations to adopt. In the 4 to 6 year time frame, certainly we're going to see in the direct-to-consumer market significant contraction. We looked at this market and a number of people that we spoke to in the market that were that's all they do was work in the telehealth space. We came up with close to 200. It depends on how you want to count it, but between 220 and 260 vendors in this space. We're going to see significant contraction there. in the next 4 to 6 years as the larger ones that do gain true brand recognition in the market gobble up the smaller vendors, or the smaller vendors simply die off. There will be certainly outpatient expansion. And what I mean by that is, in particular, is with the outpatient expansion of telehealth, it's going to move into the long-term post-acute care, skilled nursing facilities, even physician-centered medical homes, for example. These are markets that have not been very well served to date with telehealth services, but we see a pretty significant opportunity there. And we're going to see more preventative health. I think CMS, at least recently, has been showing a lot of flexibility with regards to waivers around some of its new APM models and, for example, the CMS MSSP. And I think that's going to create open more doors, more windows for the adoption of telehealth services. And I think we're going to actually have much better analytics to actually see how telehealth contributes to utilization management, et cetera, and be able to project a better ROI, return on investment. And in 7 to 10 years, I think we're going to see a massive shift. This is going to be slow, but within at the end of 10 years, we're going to see the smart home become dominant, where it's going to be, your voice, your virtual assistants, kind of chatbots, AI type services provided through, say, an Alexa type service is really going to become the front door to care. And they're also going to be able, through using these kind of interactive systems, be able to help educate a patient in terms of, taking their meds, medication adherence, etc., monitoring them with the sensors, the passive sensor networks within a home, and also be able to dynamically alter care plans on the fly as the data comes in and as modifications are made to the patient based on more real-time feedback. I also think the sensors will become much more interchangeable, where we'll be able to switch them out relatively easily, because we'll be using a very common platform to collect that data, load it up, and put it into the context of that given patient and that given clinical model or clinical care plan that that patient is subjected to. Okay, that's the webinar. So what we have now is your opportunity to ask questions. So if you go to the webinar kind of dialog box, we have there's an area where you can actually start clicking in your questions. So I'd like to bring in Anne and Brian into the conversation now, and we can move forward.
Thanks, John. Before we move into our discussion, one person had a question directly about the report. Does it examine, or can you address how the B2C models are competitors with healthcare providers by using vendor-employed clinicians instead of the healthcare organization-employed clinicians? So basically, the direct-to-consumer business model versus white labeling as a B2B model.
So right now, we're seeing the vast majority of the direct-to-consumer vendors doing to a certain extent, they're doing the direct-to-consumer. A lot of them are selling into the payer market. The payer market's been pretty good market for them. So in that scenario, they have to provide the physicians for that payer relationship and the telehealth services that they're going to provide. Now, when they do a white label, so that's kind of a B2B to C. When we look at the B2B market, and I would say that there's that being said, what I would say when we say direct to consumer, we're saying direct to consumer kind of a B2C model, but honestly, it rarely is straight to the consumer, where a consumer will just go to one of these websites and just pull up a telehealth service. Oftentimes they get pushed to it, or most often they get pushed to it through their payer or through their existing provider network. So when we look at the B2C model as it relates to healthcare organizations, what they're going to be doing is bringing this on, adopting the platform and layering in their own providers on top of that platform to kind of build their own personal brand within the region that they serve. Brian, is that something that you're seeing as well? Just from
Thank
your
you.
perspective at the university hospitals.
Absolutely. And again, thank you for having us, John. I would venture to say that as we dive deeper into the marketplace, we explore the role that we as an institution and as a healthcare system in Northeast Ohio want to play. And we are experiencing our interactions with different vendors that want to play a role and directly provide that care to the consumer. Obviously, in the long term, we want to obviously provide as much of the care to our current patients and our patient population as possible, compete within the same marketplace. And as the technology moves forward and the provider and patient engagement moves forward, be a consistent force. We're going to have to work with vendors to obviously meet the needs of our populations, but at the same time, we're trying to figure out what role we want to play in terms of there are going to be aspects of this care that we want to own, that we want to keep to ourselves and to our internal providers. And there's going to be aspects of the care that at this point in time we're not ready to provide, and we'll have to rely on the vendors in that B2C model to make sure that patients are getting that same care, whether it's branded under our brand or whether it's a outside source. That's kind of where we're exploring.
And Anne, have you seen anything from your vantage point at the American Telemedicine Association in terms of any trends around that?
Yeah, and thank you, John, for having Brian. This is great, and I appreciate having been able to see your report in advance. It's great work. I wanted to comment on what we're seeing across, because the ATA represents literally hundreds of not only vendors, most of whom were profiled in your report or mentioned in your report, as well as delivery systems, academic medical centers, as well as payers. And I think, and Brian should comment on this as well, one of the drivers that you allude to in terms of the employer market, there is a lot of interesting activity happening in specific geographic markets where employers are engaged in a lot more direct contracting. And I'm talking about more than just the centers of excellence that we're seeing with the large national employers like the Boeings of the world, but really in specific markets where there's direct contracting. And so on the part of the employer directly to the delivery system, consequently, I believe you are going to see a lot more innovation at that level. And speaking back to expectations on the part of consumers, the employer is really pounding on that in terms of what's going to make things best for their employees to enhance their productivity, their resilience, and so forth. So I think that's a factor that should be called out as you think about what's happening with the delivery systems as they interact with some of the different vendors.
Thank you, Anne. Moving on to our other questions. For everyone, what part of the healthcare delivery chain will be most impacted by telehealth service models? We kind of identified these in the report, but especially Anne and Dr. Zach, what are you seeing from your places at the ATA and university hospitals?
Brian, do you want to take that first?
Sure, I can go first.
Okay.
It's interesting as we evolve, and I think the point that you were leading me into with your last comment, Anne, which is fabulous, is really that as we, as an institution, take on more risk, as we accept more risk and more of the totalitarian of services that the patients and the payers want, and especially their employers, we're going to have to create contracts that provide services at the level that the consumers want, whether the consumer being the patient or the consumer being the employer. And so we are already doing this. We have, at we have over 500,000 lives under our ACO. We're increasing the number of risk contracts that we are making with our local employers and community. And being able to provide telehealth and virtual healthcare services is going to be a major part of how we basically keep our end of those contracts in many different ways. In terms of the question itself, in terms of how the healthcare delivery chain will be most impacted, we are, like many out there, I think we're certainly at the beginning of a lot of the big changes that John talked about and that we're about to see. We are contracting with one of the vendors you mentioned, MD Live, to provide the direct-to-consumer piece So we are seeing how that's impacting sort of that urgent need or the immediate need cases. We are providing our own providers. I don't mean repetitive. Our own physicians are manning that in our local community and trying to get some branding there. But that's really the low-hanging fruit. As we grow our institutional culture to include these services, we want to see it throughout the chain, specifically in pre and post-operative care, in chronic disease management especially. And so we are taking an approach, not so much rolling it out as an overall culture and mandating its use, but finding the champions in different levels of care throughout the adult and pediatric systems, where we want to find both, at the moment with the pay parity issues, the reimbursement is appropriate, as well as finding value in the care we're providing. So the areas that are being most impacted right now are still direct to consumer, urgent, things like that. But we're seeing tremendous psychotherapy, behavioral, emergency psych, telestroke. We are seeing tremendous impacts in those programs right now.
I would say the only comment I would add in terms of an overarching theme and the way we talk about it at the ATA is that if all we do is use technology to replace a visit, we'll have sold the whole thing short. And so we really have to use telehealth technology to reimagine care and ultimately use it to expand capacity, because we have insufficient resources across the board to deal with what are growing needs in different populations. And John, you commented on rural health. I would say that one of the myths associated with telehealth is that it's only for rural communities. And we all know that there are a number of urban medical deserts as well. So that's the kind of theme I think we're going to see play out and ultimately impact the delivery chain positively, hopefully.
Thank you, Anne and Dr. Zach. Moving on, what are the three biggest challenges to operating a telehealth service at scale? I think Dr. Zach, maybe you should take this since you're our key provider.
Yep. It's interesting. We as we jumped in and tried to create this culture of obviously, and couldn't agree again more that it should not replace the visit. It becomes an extra tool we use to improve the patient-provider relationship. We initially assumed that our patients would be the easier engagers, that it would be harder to get providers in, and we've seen a little bit of both those challenges. As I've tried to grow programs and work with our amazing leadership at UH to build programs that are based on this technology and use it as tools, one of the hardest things we've found in the pay parity realm is bridging the gap for the champion providers between the standard fee-for-service or RVU-based reimbursement systems and moving towards that value-based care that might involve virtual or telehealth services. It doesn't happen with the flip of a switch. And so as we do have providers who are engaged and we do have providers who want to provide this care, we need to be able to make them whole. And so that takes institutional level support, that takes investment, but that's been a challenge because so much of what we've done traditionally with our providers has been a fee-for-service RVU model. And also secondary, I would say patients like to say they're engaged. We all know the data on the percent, over 95% of our patients now own smartphones. They're holding the technology in their hands, but when given the options, a lot of them still choose, I prefer to do this in person. And so it's a lot of education. It's a lot of engagement on the front lines. And those are the biggest challenges I think we've faced. The technology is going to drive itself. I never see the technology as a challenge. It's being built. There are amazing disruptors and innovators in the industry. I think that we can build programs without any hesitation using partners in the field. It's really about making our current culture grow at the speed of which, or even close to the speed of which, the technology and the environment is growing.
Thank you. John, Anne, did you want to add your own thoughts about challenges to operating at scale?
Well, this is John, and what I'm seeing is, besides an echo, is that what we've got going on here is, I think the cultural issue is very real. And I think, to what Dr. Zach had referred to, as the parity issue is still very big. And I think, there's certainly the parity, but I think it's also just a cultural shift in terms of getting providers comfortable with this new modality of delivering care. I think, what will be, I remember I was at a conference last year, and a very large Midwest system, a little bit further west than you, Dr. Zach, had adopted telehealth, and they had a lot, and this was a few years ago when they started on their journey, and they had a lot of pushback from the physicians, their affiliated physicians in network. And the argument they came to him with was either we do it or it will be done to us. And that seemed to win over the providers. And yeah, we got to move in this direction. And they've actually had a very vibrant and healthy telehealth program that has grown quite significantly in the region that they serve. But again, similar to what you had to do at university hospitals, is that they had to bridge the pay parity gap between a traditional RVU fee for service type of model and what would be under, say, a bundled payments or some of the new APM type and reimbursement models that are beginning to come into play here in the marketplace. But that brings a big question back to you, Brian, and I was wondering about this. Do you see, with regards to this, this whole migration to taking on more risk, is there, as well as some of the recent rulings of CMS on opening up the doors a little bit more, for example, with the Medicare Advantage, making it a basic service, do you see that really accelerating the growth of these services going forward and be able to scale at a much faster rate?
I think it's definitely the tipping off point. In terms of the downstream communication of these changes, it's beyond, as we take on risk and as we know that we're getting a payment from a payer for the totality of care, and we want to provide all that care at all different levels. How we reimburse our providers is a different matter. And until our institution is ready to acknowledge some of the technological advancements that telehealth and virtual health provide, and are able to partner truly with our providers to allow for what's truly high quality and value and access for the patients within this realm, we're going to see we're going to feel the challenges of that rocky assimilation. I think the end is positive. I think the outlook is clear, but it's going to take some cultural changes at all levels of the institution, not just leadership saying this is a good idea, we have to do it or somebody else will, but down to the level of how do we support everyone within the institution to weather the changes. Some of the biggest concerns on the payer side is, will the integration of these services lead to overutilization and costs? And as we take those risk models, we have to manage that. To some extent, yes, but with post-ops, readmission rates, certain disease group states, such as diagnosis-related groups, such as congestive heart failure, diabetes management, we already have seen in some pilot programs how the utilization goes down, not up. And we need to be able to create programs that all of our providers, beyond the champions who are engaged, can support. I hope that answers your question.
Sure does. Thank you so much.
Going further, how important is it to engage providers in these models as well, and to make sure that they are fully supporting especially the white label business model, so that they are ready to engage their patients and make sure patients view telehealth as one of their many options to get care?
Well, I can certainly speak to what we're seeing and how we're talking about it with our members within the ATA, which is, on the one hand, as an association, what we really want to do is change the story about telehealth and talk about why we're here, which is to ensure that people get care where and when they need it, that when they do, they know it's safe, effective, and appropriate, and that ultimately we can do more good for more people. And so from a policy perspective, that really drives a lot of our thinking, our policy priorities going forward as well. But then the way it plays out in terms of education and resources for our members is that we need to do more in terms of tools, resources, education to accelerate the adoption and engagement by both providers and consumers in telehealth. So I think, to Brian's point earlier in the conversation, there's plenty of technology. That's not the issue necessarily. Maybe our imagination is a limiter in terms of how we can use technology. But at the end of the day, it's really about driving adoption and acceleration. So again, some of this goes back to myths associated with telehealth. And one would be potentially that it's a threat to physicians or clinicians or providers. And in point of fact, there's plenty of evidence to suggest that it can be used to support a much better work-life balance, much more effective practice of medicine, and really allowing clinicians to practice at the top of their license, if you will.
I completely agree with Ann. As we've tried to engage providers, we've taken the strategy at university hospitals of allowing our champions to build some programs in a case-based scenario as opposed to a total program or department. So we have a travel medicine clinic. We have some behavioral health clinics that are focused on oncology, recovery, and remission. We're rolling out some asynchronous teledermatology. Post-op, we're going to really push this year surgical post-op within global reimbursement schemes. The providers are driving this. We are providing the tools as an institution, and that's my role and the role of some of the fabulous leaders I work with. And by doing so, instead of rushing it or forcing it upon the providers in the different departments, you're allowing the providers to be the creators and the innovators and to take such ownership over the success of these programs that the word of mouth spreads, and we're seeing it. We're actually having to expand our small department to be able to kind of help assist these programs as they continue to grow and we have more requests. Once the case-based scenarios are successful, we then go to the leaders of those departments and say, how can we roll this out for other cases and make it more of a culture within your department? And so allowing the providers to really be the engine of this train is it slows down the process, but I think it makes it more effective. We're there to support it. We're there to hand it off when it's done and let them provide the high quality care that they came to start with in whatever modality it is most effective and most efficient, as Ann said.
Okay, I have a quick question for you both, and maybe we can start with you, Dr. Zach. But one of the things I brought up over the course of the presentation, something we found in our own research on this market that has been, an area of concern is how do we create the longitudinal patient record when a patient is going to, or a consumer is going to many different venues of care? For example, a telehealth encounter, an urgent care encounter. I mean, there's other places that they could be getting services as the whole front door to care shifts. But I'm wondering, from your perspective, as a physician, as a doctor, how do you move towards being able to ensure that you have that longitudinal patient record? Is it through a close linkage with the payer on a given contract, or is it something? Is it a responsibility? Ultimately, is it the responsibility of your organization, of the payer, or of the patient themselves? And how does that get back into, say, the workflow of a clinician that happens to be working with a given patient in a given encounter?
The approach we've taken is that and this is both to obviously uphold the quality you were just referring to in terms of creating a single or longitudinal based record, but we want to make it easy for the physicians providing this care as well as for the providers not providing the care to be able to access that information. And so for our for the majority of our programs, we are using our ambulatory EMR as our record keeper. So the visit, the templates and the location of the visits is no more harder than to find than if it was a face-to-face visit. What we've done is created appropriate adjustments and documentation to the individual record itself that shows that this visit was performed virtually. Our compliance and legal teams have worked out some wording they're happy with. That's a single checkbox at the top of any standard visit note that shows it was a virtual visit as opposed to an in-person visit. What this has accomplished is not only does it create a consistency within the record for other people looking in after the fact, but it gives the provider, it's not one more program or one more template to learn. It's their templates they're used to. They're just providing the information as best they can within the realms of the virtual visit. I think this is critical. Everyone talks about the long-term goal of getting to a single unified record-keeping system in this country because of the ease and the importance of the transportability of that information. And as organizations trying to dive into this market, I think it's really important that we don't get what one of my mentors likes to call platform potpourri. We have to keep it simple. We have to keep it easy to access and easy to manage for the sake of the patients, or else it's not high quality and it's not value-based care.
John, the only thing I'd add to what Brian said is that for us, as we look at this, we think it is a huge impediment to adoption by providers. And so we are launching an initiative beginning 2019 to study this issue of interoperability as it relates to all the different, the platform potpourri, as Brian refers to it. So to really isolate and articulate what the issue is and what needs to be done and who's responsible for getting what done. So that's is something that we're really going strong on, and stay tuned. I would say the other thing, though, that contributes positively is some of the work that's being done with the Karen Alliance, for example, where there's an acknowledgement that there are standards that can be used so that people can get access to their information anywhere. And certainly by some of the external players that we're seeing, non-traditional healthcare players like Apple and so forth, we're going to see, again, some of the traditional challenges of proprietary systems and so forth really get eroded, because all that's going to do is serve to accelerate consumer expectations and demand for greater visibility and access to their information.
Thank you, Anne. One of the things that I mentioned earlier, the health affairs issue this month, and in reviewing that in advance of this webinar today, one of the things I came across was that a rather startling statistic that there are over 160 telehealth bills in 44 states that were introduced in 2018. Clearly, and we've also seen this as one of the adoption barriers, is some of the licensure rules and how it's really pretty much almost impossible to have a nationwide telehealth service because of the state-by-state rules and requirements that all differ a little bit. So my question to you, Anne, is what is being done about that? How can we as a country, not a state, but a country, begin to rationalize these multitudes of various bills to have some consistency in policy across the country? Is this something that has to be taken at the federal level? Or is this kind of like what we do with physician credentialing? It can only happen at the state level, and we just have to slowly wade through this whole process.
Well, I would say that, again, coming new to the role at the ATA as well as new to the association world, I have abundant optimism about our ability to change this, not necessarily quickly, but I have a lot of optimism. And certainly the progress, albeit small or incremental, with the licensure compact for both nursing, which is actually doing a lot better than physicians in terms of the number of states, is positive. It's moving, in the right direction. I would say, though, that if we believe that some of these restrictions are put in place to ensure that people get safe and effective and appropriate care, which I think is in fact most likely the intention, we have to be very clear about where they are not being used in that instance. So in other words, what I mean by that is if restrictions are in place to protect a self-interest of one kind or another, then we have to be poised to call that out and to educate the public and lawmakers and regulators, both at the state and federal level, to really implement change and make that happen. Because I will say that the access issue and the shortage of clinicians is not necessarily getting better. So the fact that most counties in the U.S., for example, do not have access to behavioral health resources, and yet we know from the work that our members have done and the studies that telemental behavioral health services, doing it virtually, is as good, if not better, than doing face-to-face. Then using those kind of proof points, we have to call out and really address some of these impediments that are there for no other reason than protect someone's self-interest as opposed to protecting and supporting the health and safety of our citizens.
Brian, any thoughts on that? In terms of what, I mean, how's the experience been for you? I mean, you're in Cleveland, so you're right on the border of Pennsylvania. How are you strictly serving just the state of Ohio, and therefore these issues really don't come into play for you? Or in your broad vision of what you want your telehealth services to become, is this something that you're grappling with as well in your organization?
Sure. So, I mean, obviously, it's easy to live within your own community and within your own backyard, if you will. As Anna was speaking, I was thinking of the two ways it most impacts our plans and our care are for the physicians providing a little bit more of that direct-to-consumer model. We're seeing that a lot of the that you can only operate within the states you're licensed in, and the majority of our physicians who are doing this for our patients are finding that there are providers employed by many of the top tier companies that this is what they do for a living. They're licensed in literally 8 to 15 states, and they sit online and, for lack of a better word, gobbling up the patients. And that's their job, and I'm not criticizing. But where it affects our care is that as we're trying to get out there and provide care for our patients and provide a level of service that serves them and brings them back to the medical home, we're struggling to compete within that national environment. More specifically, we have providers, especially some of our top tier and nationally known surgeons, who want to provide preoperative consults and second opinions. But we are trying to really explore how some of these regulations in terms of state licensing will affect their ability to do some of those consults and evaluations virtually. We want to expand our reach. We want to show the country and the world what we have to offer in terms of our amazing physicians and providers. But we have to make sure, as we navigate it and as we grow within it, that we are obviously, for lack of a better word, following the rules. And so meeting that. So that's the way I've seen it affect us.
Great. Thank you for great answers, Ann and Brian, and thank you for just a fabulous input, and just your expertise and knowledge on the subject has just been phenomenal for this webinar in terms of balancing kind of our view as an analyst firm and your view from an organization that looks much more broadly at this whole issue of telehealth and the promotion of telehealth services in the country. And of course, Brian, your feet on the ground, firsthand experience is very well appreciated and gave a lot of nice color to this webinar. I'm going to hand it off to Hannah now, and she'll do the final wrap up.
Thanks, John. And thank you everyone for joining us. I just want to apologize for all the questions we did not have time to answer. They were excellent. We had a list of them ready to go, but alas. If you still have questions, feel free to email John. He's at john@chillmarkresearch.com. He can answer any further questions, maybe pass you off to Anne or Dr. Zach in case he can't handle it. And I'd also like to remind you that a lot of the answers you were looking for are also in our report. You can find more information on our website, chillmarkresearch.com. I will also be following up with you in an email with the recording of this webinar and the slides and more about how you can learn about the report. If you have any other questions, feel free to reach out. And thank you for joining us.